Welcome to the No Plateau Podcast for stroke and brain injury survivors, their caregivers, and the therapists helping them to break boundaries in their recovery journey. Hosted by Henry Hoffman, occupational and clinical therapist, this podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. And now, here's Henry Hoffman.
Hello, everyone. Welcome to another episode of the No Plateau Podcast. I am your host, Henry Hoffman, and excited to be with you today. Today, we are going to talk about a fairly new treatment option for stroke survivors in the chronic stage called Vivistim Therapy. The technology stimulates the vagus nerve during therapy and daily activities to help improve upper limb function for stroke survivors. This pairing helps strengthen the brain connections needed to improve hand and arm function, kind of like providing a boost during your treatment. To help me discuss this practical application of VNS, I invited a wonderful OT and colleague of mine who performs Vivistim treatment with her clients in Florida. Please welcome Amanda Saylor. How you doing, Amanda?
Hi, Henry. I'm doing really good.
Great. Yep. Well, before we begin, why don't you share with the audience your professional and personal background, if that's okay?
Yeah, absolutely. So let's see. I think I've been an OT for maybe 8 or so years. I graduated from Rush University in Chicago, and then I moved to sunny Orlando, Florida, where I've been working for Advent Health since I moved here. And I've really spent the great majority of my career in the outpatient setting, but focusing on neurological rehabilitation. So really, ever since I started OT school and looked into that, stroke rehab specific to the upper extremity, hemiplegia has been my passion and something I wanted to spend majority of my focus on. That's what I've been doing. But now, kind of in present day, I was leading the team, the neuro OTs across Advent Health. That was about a staff of 25 to 30. Now I just treat part-time. I do now work as a consultant with Microtransponder, who makes Vivistim. And I can kind of talk about how that came about and why I really was passionate about it and wanted to do more with Vivistim. And I also have an Instagram page with my coworker and friend, Becca Carr. We shared like different treatment ideas and tips on our page, neuro_OTs. I think that about wraps it up.
Yeah, I think that's how we first met. Maybe I saw you on Instagram. I know you've been using some of the Sable products over the years, but I remember seeing your awesome videos working with patients, which is pretty cool. So, well, I'm glad you're here. I'm excited, obviously, to talk about Vivistim and the advances over the last couple of years. But before we start, if you are a clinician and have been living under a rock for the last 20 or 30 years, I think let's set the stage and review what you've missed regarding best practices when treating stroke survivors over the last 2 to 3 decades. So to start, we know that the brain is soft-wired and has the ability to reorganize. That was not the case prior to the 80s with Dr. Merzenich's groundbreaking studies. So the good news is neuroplasticity is basically alive and well. We know that because we rewire on a daily basis. Now, that could be good or bad. So we can, if you have PTSD or depression, that's a negative example of neuroplasticity. But if you want to learn a new skill or a new language, if I want to learn Chinese tomorrow, and I don't know if I can do that, but if I did that over a course of a year, I'm rewiring my brain. So that happens on a daily basis all the time. So the good news is neuroplasticity exists. Bad news is it could be good or bad. So if you have a bad experience, you're going to rewire your brain negatively. Obviously, a good experience, different story. And of course, if you suffer from a physical disability, your goal is to improve your motor performance, and that can be done through neuroplasticity as well. We know that embracing Kleiman Jones' 10 principles of neuroplasticity is a must to make continued progress. Things like use it or lose it, salience, repetition, and intensity are essential. So we do know that. We know treatments like constraint-induced movement therapy, where you restrict the movement of your healthy limb and force you to use your affected side for a period of time, or task training or functional task practice or task-specific training, how you like to call it, are basically the cornerstone to all of our recovery. They are like the leading actors, if you will. We, sticking with that analogy, the supporting actors then would be our ancillary interventions like electrical stimulation. These are things that are going to prime the brain as well. Bilateral arm training, robotics, mirror therapy, mental practice, vibration, sensory stim, just to name a few. So those are kind of like the supporting actors. They're not the main event or the first round draft choice, if you will, but they're beneficial to incorporate. Now, if a client does not have the physical ability to perform task practice or constraint-induced movement therapy, then he or she will need a device that's going to augment that movement. That could be eStim, that could be dynamic functional orthoses or gloves. And frankly, that's how SABO started. SABO started over 20 years ago when constraint-induced movement therapy was extremely popular at first. But the problem was a lot of people did not qualify because they had severe hemiparesis. They could not extend their fingers. They could not extend their wrist. So they needed something functionally to keep their hand open to do grasp and release and start that task practice. Recall, the research heavily supports task practice, task training, purposeful movements. But if you don't have the hand function to actually incorporate the hand purposefully and meaningfully, you're kind of out of luck, right? So by having those types of devices available to you, you can then embrace what the research wants you to embrace. So now I've been around long enough to know, however, that even with the robust evidence, even with task training, even with all those ancillary interventions that are very, very effective, many clients still do not succeed following these various interventions. So we have a long way to go. That is why I'm excited, Amanda, to talk today about Vivistim Therapy, because stimming that vagus nerve while performing all those wonderful treatments might be the 1-2 punch that is needed for these folks. So sorry for that introduction. It's a little bloviated a little too much, but did I capture the last 25 years in a nutshell?
I absolutely think you did, and you really set the stage for when we talk about the type of therapy that needs to be paired with Vivistim, because everything you mentioned, like the amount of repetitions and salience and task specificity, like those don't disappear with this newer option or new technology. It needs to combine with those things. So I think it'll tie everything together.
Great, perfect. Well, let's dive in. Why don't we start off with discussing what the heck is Vivistim and why was it developed? Let's start there.
So let's start there. So Vivistim is basically vagus nerve stimulation paired with therapy. It cannot be one without the other. Okay, so someone cannot get a vagus nerve stimulator that was made for epilepsy treatment and then think that their arm is going to get better just because they have this device. This is a very specific VNS device, and the settings were made and tested and set at the levels that they found after decades of research to be effective to enhance neuroplasticity when paired with therapy. So basically, the VNS part of this is not necessarily new, just the settings, as I mentioned. So vagus nerve stimulators in itself and the procedure, it's actually been going on for 25 years, usually to treat epilepsy or depression. So the actual implant procedure is not new. That is an outpatient procedure. Usually takes about an hour. And typically neurosurgeons will do that or similar. Usually a surgeon who's been placing those for the treatment of epilepsy. So that's the one piece of it. The other piece is that what's different than epilepsy, when the device is typically on all of the time, is that this device is only going to be triggered on when the patient is in the clinic with a trained OT or PT, and when they're at home doing their specific home exercises or their functional tasks or their arm and hand. So this VNS paired therapy has been FDA approved for just our chronic ischemic stroke patients with upper limb deficit. So, we could maybe mention there's potential for advancements on what other deficits or what other conditions. But right now, just the most important thing to note is that FDA approval is for chronic, which in general is usually 6 months or around there. And there's no too chronic for out labeling. There's actually been patients who have had Vivistim that are over 40 years, or there's been one patient, I should say, over 40 years post-stroke, which is crazy. And then, like I said, ischemic stroke with just arm and hand impairments. So what that looks like is the patient would have this implanted, and then they would go to therapy. And again, the trained therapist would have, basically it looks like a remote or a clicker or a presentation clicker, really, where they would be stimulating that vagus nerve during basically every upper extremity task movement. But we can't just be doing, 10 or reps of shoulder flexion and rest, and then 10 reps of bicep curl This does need to be task-specific training, at least primarily, and at least 300 task repetitions. And the type of therapy and the number of repetitions weren't just pulled out of a hat, like, hey, this sounds like the right thing to pair this with. This was, again, decades of research, even starting with animal trials with looking at rats and saying, okay, let's do a distal task and let's see how the mapping of the motor cortex changes with BNS. And then let's do a proximal task. So a little too much to go into detail today, but there's enough evidence of why they decided when the pivotal trial was completed, of why task-specific training was chosen and why it had to be at least 300 task repetitions.
Well, yeah. And then obviously it would be going against research if you did go to the open chain exercises and instead, I mean, if Vivistim's protocol was do 3 sets of 10 bicep curls, 3 sets of 10 shoulder flexion and wrist extension, you may have a hard time getting neurotherapists to jump on that bandwagon just because the research is, although strengthening is a component of overall recovery, primary player is going to be purposeful, meaningful, task-specific activities. So by having this, Vivistim, and I know we'll get into a little bit more about the benefits and how it works, but but what I'm hearing is the client goes into the clinic, the clinician is trained to do evidence-based strategies such as task-specific training. While they're doing those task-specific strategies, they're then somehow getting stimulated, is that right, with the vagus nerve? And how does that process work? If you can kind of take us into your clinic and pretend you're working with a patient, what would that look like?
Yeah, so kind of to give you an idea, there's a very simple laptop, and I say simple meaning that the laptop opens up and it's just the software. It's called SAPS, but it's a software that just works for Vivistim. There's not like there's Wi-Fi, there's no patient identifying information on this laptop. And then there's a cord with a wireless transmitter. So that is where the therapist would turn everything on and actually be able to connect to the patient's battery pack or implantable pulse generator. That's, similar to if you imagine any other implantable device like a pacemaker or loop recorder, like there's some type of battery pack. So that's what you're connecting to. So once connected, which again is very simple, really, then you would start your upper extremity task practice. So that might look like, depending on the patient's level, which we'll kind of get to that point, right? Because as you mentioned before, hard to do task-specific training if you don't have some type of distal function specifically. But maybe you'd have your patient holding a bowl, stirring that bowl. Maybe you'd have them simulating spatula movements. Maybe you'd have them preparing to wash their car, like whatever is salient to them, whatever is meaningful and task-specific. And potentially, let's say if you're going to be stirring a bowl, right? Maybe when that patient is reaching for their large spoon, you're going to give one stimulation. They grasp the spoon, another stimulation. And then as they're stirring, let's say if that's a repetitive movement, maybe you're stimulating every 2 or 3 seconds while they're doing.
I compare this to triggered e-stim, right? So is this the same as triggered e-stim where you literally hold down the button, if you will, and the stim is constant? Or do you click it and suddenly that generates a total of 3 minutes of continuous stim, 5 minutes? How does that work, or how does that differ from the normal triggered button on e-stim?
So this stimulation, and if you look at the settings, it does remind you of electrostimulation. It has a different pulse width and frequency and intensity, right? But the amount of time of stimulation is 0.5 seconds. And then there is, again, without going into too much of the deep science today, but there is a bit of a period where you're still getting that benefit in the brain, even though the stimulation lasts for 0.5 seconds, your brain is still getting the activity for a longer period. And kind of backtracking, I don't think we talked too much about what is actually going on, why the vagus nerve. So we might remember from school, the vagus nerve is, I believe it's our 10th cranial nerve, if I remember. And it's usually called the wandering nerve. It's very long. It does so much, but we often think about the autonomic nervous system. So sometimes when it comes to vagus nerve stimulation, there's a lot of questions about, well, isn't that going to affect, this, and that? And, how is this affecting upper limb recovery post-stroke? the left vagus nerve is very different than the right vagus nerve. That's something that was new to me when I heard about Vivistim. The left vagus nerve has 80% afferent fibers, so they're going upwards toward your brain. And because there's different branches, the placement of the vagus nerve is in a specific area, so it's not even going to impact like the cardiac area because that's a lower branch. So if you kind of look deep at the anatomy, you can understand why it's a fairly safe procedure and a device in general. But when the vagus nerve is being stimulated and then it's going upward toward the brain, there's going to be an increase in the amount of neuromodulators released, like acetylcholine and norepinephrine. And then we know from all these decades of research that there's even about a 3 to 6 times increase in neurons overall. So how I explain this to patients is that your potential for neuroplasticity or your potential to make new connections increases with Vivistim. So that's why you can't just stimulate your nerve and sit on the couch because your brain would have the potential, but then there's nothing to be paired with it unless you just wanted to get better at watching TV. But I don't think that's what we typically want unless we're holding the remote and trying to click, right? So we need to be pairing it with something.
Yeah, no, that makes sense. That's really good. And thanks for clarifying the trigger button and how that works. And yeah, so by adding the Vivistim to the stroke patient's treatment, it's kind of like, you're trying to muscle build and you want to have protein drinks to enhance your overall muscle growth. We're trying to boost or enhance in this case, neuroplasticity and recovery. So why don't we dive into the benefits and the outcomes? So we know what Vivistim is now. We know a little bit more about the vagus nerve and why we're doing it. What are the benefits and outcomes at this point? What does the research say?
And then I think too, before I mention what the evidence shows, I think sometimes there is a little confusion. So before there are any assumptions, I want to point out that, especially since we were talking about the East and two and comparing, when the outcomes were looked at, it doesn't necessarily mean that, a patient has improvement right when we are stimulating and all of a sudden they're going to have improvements right when the stimulation is on, or if they need the VNS to be on to have the improvements. Because we're making changes in the brain, even if we did our pre and post testing on outcomes when the VNS was not on and we were not stimulating, that patient should have the same should still see results because it's not an immediate change just because we're stimulating the nerve. So I just want to clarify that too, because sometimes it can be a little confusing. But
yeah, well, that kind of reminds me of FES. I mean, sometimes people only improve ADL activity because they're using functional electrical stimulation to complete the task. But then when you don't stimulate those muscles to complete the task, they obviously cannot do the task. In this case, that's not necessarily going to be the same situation. You're not relying on that stim to have the progress that you need. This is just part of the overall treatment intervention. Got it.
Yes. And even some patients still, understandably so, they still, there's just some confusion. It's new. And they might say, hey, I did X, Y, and Z today. And I didn't even turn my device on with my magnet. And I have to try to educate well, that's because it's not an immediate effect, but that's besides the point. But as far as outcomes go, so there was a pivotal trial, which I'll go into more detail, but even not even just that, but after study after study, really the same outcome was found, the same amount of difference from a group that receives intensive therapy with high quality therapy, probably higher quality than the typical clinic would receive, right? With primarily task-specific training compared to a group that had task-specific training with VNS. There's always been a documented 2 to 3 times improvement rate on several outcomes, primarily the Fugl-Meyer and the Wolf Motor Function Test. Those are kind of like, as far as motor control goes, in the published work, those are kind of the 2 major ones. And also the motor activity log was in a work too often. But maybe let's dive into the pivotal trial a little more, because that is really what led to FDA approval and kind of why we're here today, why this is an option for patients. So this was actually published in the Lancet in, I'm missing out my date. Was it 2020 or 2021? FDA approval came in 21. So it was sometime in that period. So I want to say it was 21. And if you don't know, the Lancet is one of the highest level journals. So to get a medical device published in that journal was a large deal as well. So But they had 108 participants in the study. And they, just like any other randomized controlled trial, they did split it basically in half. And they had their control group receive therapy, task-based training primarily, 3 times a week for 90-minute sessions, each of those. So 3 times a week, 90 minutes for 6 weeks. And then they compared that group to another group who had the same exact type of therapy. Both groups had the VNS implant procedure done prior to this, but only the intervention group had their device turned on. Since the great majority of people cannot feel the stimulation, it's at such a low level. It's actually typically or in the study, it was 0.8 milliamps. At such a low level, you typically can't feel it. So this study could actually be triple blinded. The patients did not know what group they were in, if they were control or experimental. The therapists did not know, since they were stimulating no matter what. And then the assessors or the research team did not know either. So you don't hear about triple blinded studies very often. So it's a little different. So then when they looked at the Fugl-Meyer primarily, they saw that 2 to 3 times rate of improvement or a rate of like a difference from the control group to the intervention group. And what that looked like was the VNS group improved on their Fugl-Meyer by 5 points after 6 weeks. And the control group was about 2 points. I have to look back exactly, but right around there. But I know the intervention group was exactly 5 points. And then they got to go home and use their magnet. So I didn't mention that yet, or very specific with that. But in the clinic, you are paired VNS. At home, you have a magnet to turn on your device for periods of 30 minutes, up to 8 times per day. So in the pivotal trial, it had to be very controlled. And we know our patients. There's some people who are going to do their HEP too often, like 3 times a day. And there's going to be patients who don't do it at all. So to control for that difference in motivation, they did not use the magnet at all in the first 6 weeks. So they had that change without even using the VNS outside of the clinic.
Wow, that's pretty impressive. And you mentioned 90 minutes per session in the clinic. And by the way, these are 6 months or greater post-stroke, right? Is that the defining chronic for you guys? For that study, rather? And then, so 90 minutes is tough, though, because not a lot of clinics are set up to do 90 minutes of treatment. Has that been, not to digress, clearly for the study it worked, but do you want to mention just your initial thoughts on that? Is 90 minutes a problem? Because normally when I think of sessions, I think of 45 or 60 minutes.
Yeah, no, and you're exactly right. Especially an outpatient, you're usually, if you're lucky, if a clinic can still offer one-on-one care for the neurological population, it is, at least at my clinic, we do 45 to 60 minutes. So I will tell you, when I first learned about OSTEM, it's probably been about 2.5 years ago now that I was reached out to for my clinics to kind of see if we wanted to get the program rolling. That was my only holdup. The data was there. The evidence was clear as day of why wouldn't you, if it was me, why wouldn't I get Vivistim if I had a stroke and had upper limb deficits? But as far as making it work in an outpatient clinic, the 90 minutes is really the only barrier to offering this. So now that I've kind of learned, I guess it did take some effort on our end of, is this worth it? And why do we want to try 90 minutes? And, are we going to get reimbursed? But I think the why is what came first. And that was that, not even just the pivotal trial, but we know patients need more time in therapy. We know they need more repetition, and they can't always get those on their own. They're not skilled and trained like we are, right?
The home program, though, if you're saying up to 8 times a day for that research study, it sounds like most people, well, again, there's weekend warriors, and then there's not compliant folk, repeat offenders, we call them, or then there's the ones that are super compliant. And by the way, if you were compliant prior to your stroke in life, whether you went to the gym or chances are you're going to resort back to your normal behaviors, unless you're motivated by fear, right? You don't want to have another stroke. You don't want to have a heart attack. So I'm really changing my life this time. So there's always those normal challenges that we have as clinicians when we're working with patients that need to keep staying motivated or compliant.
Right. No, absolutely. So luckily now too, the 90 minutes doesn't have to be a forever. So in present day, most clinics that are offering Vivistim, the goal is to offer the 90 minutes for the first 6 weeks. And then if the patient still needed to come into the clinic, you could still offer Vivistim, but at least my clinic and most clinics will cut back down. But the reason why those 90 minutes and like why we really push for that in my health system and others is that we know, again, without going into too much detail, all this other research leading up to the pivotal trial found that is how much time it took to get in 300 plus repetitions. And we need that many repetitions because that is how long it actually takes to make real changes to our brain. And anything less, we just can't say for sure, will this be effective?
Right.
So that was kind of the driving force. And
sorry to interrupt. Isn't it sad that, and we've had these discussions, I'm sure you've had these discussions, that for decades we lived in the therapy world with 3 sets of 10. We translated over the orthopedic model and thought it would work for the neuro model, right? Well, if Jane, who has a shoulder impingement, if we're telling her to do 3 sets of 10s for shoulder flexion or scapular protraction, well, then George, who's a stroke survivor, let's just have him do it 3 sets of 10, right? And so thankfully over time and persistent science, we've realized that's comical. If you're going to do 30 repetitions, don't even show up, right? Stay home. So in 300s, some argue 300 is not even enough. So I think the key is repetition is important and repetition is going to be needed. And think if you were learning a new skill, if I wanted to change my golf swing or learn how to play golf for the first time, if I literally just did, 30, hit 30 balls at the driving range 3 times per week, I'm not going to get any better, right? So it makes complete sense. Yet the system, the healthcare system, and us, the clinician, haven't really grasped it quick enough. And so thankfully, more and more people are on board, and obviously studies like the Vivistim trial is making it apparent.
Yep. And I'm hoping this, the fact that the company like Microtransponder who makes Vivistim is pushing to keep these 90 minutes and not just say, oh, you know what, you're right. Let's just do whatever you guys can do. That's kind of the plan C instead of plan A. Plan A is to offer these patients 90 minutes as they deserve because that's what evidence shows. But I'm hoping that, a few years from now that maybe that becomes more of the norm for all patients, but who knows? But that's my hope. I do hope that Vivistim in general kind of helps stroke care, like the chronic stroke community all around. But
get that.
Yeah, but overall, we do have to keep our rehab clinic afloat and financially viable. So, as far as the reimbursement goes for these 90-minute sessions, we did have to look at that, of course. So the great majority of the patients we've seen, and even the other clinics I've spoken with, the great majority of patients actually have been getting reimbursement for those full 90 minutes, which is usually an outpatient. You'd probably be billing 6 units for those 90 minutes.
Is that for Medicare or private insurance? Who's actually reimbursed?
Kind of all of the above. Commercial plans do tend to be more likely, in my experience, to have a maximum unit cap per day of maybe when we're billing 6 units. They may want to say, we're only going to reimburse 4 units per day. That does seem to be becoming more and more common, unfortunately. And that is really the only, those plans are the only time that these are not getting reimbursed, from my knowledge. Every state's a little different, of course, and has different plans, but that is what is being seen.
And so it sounds like Medicare is reimbursing.
Yeah.
Is it for or the total treatment time or
They are, in my experience, and who I've spoken with, even in other states, straight Medicare especially is reimbursing for the full 90 minutes, usually 6 units. Mm-hmm. And even most Medicare Advantage plans that I've seen as well. So again, some might have that 4 unit maximum though. So that's as long as, let's say if you worked in an outpatient clinic, the front desk or whoever is kind of running the billing department would see that cap. Or the company who makes Vivistim can also assist with that to see ahead of time. But if that cap's not there, at least in the 30 plus patients we've seen in my system, there hasn't been an issue outside of those plans with the cap.
Okay, so that covers the therapy reimbursement. What about the actual surgical procedure? You always have the hospital, anesthesiologist, the doctor. I always get these bills. I had knee surgery 2 years ago, and it's like every month a new health professional is billing me for something that happened 2 years ago. It's crazy. The coverage for the actual surgical procedure, do you have any idea?
Yeah. I probably won't be able to answer like specifics on what it entails, but as far as the actual, like your insurance just approving it for that so that you could go and get it scheduled. If we start there, straight Medicare actually granted Vivistim a Medicare breakthrough technology pass-through, if I'm not messing up the words, but they only do that for so many different technologies and pharmaceuticals every year. So because they saw the advantage for these stroke survivors and having Vivistim as an option, they kind of fast-tracked the approval for straight Medicare. So patients with straight Medicare who qualify do not need to have like a long waiting period for prior authorization. They just have like their pass-through approval, which is great. And then of course you kind of have to go into like how much you're going to be paying for your copay, like that stuff I guess will differ. But the company could help with that, of course. And then other insurances will have to, submit for prior authorization. And because this is new, it's not built into any plans like ACVNS when they think epilepsy, because that's all that, an employee might know who's working on the insurance team. So oftentimes we have to go through levels of appeals to say, hey, like, no, here's the evidence. Here's our FDA approval. We need this approved. I will say it seems to be getting faster. Patients are getting approved quicker now, and more plans are approving. I have had patients outside of straight Medicare. I've had patients get approved in 2 or 3 weeks. Other patients, are still waiting. Some patients have they get denied and we have to resubmit. So we have to do some retesting and try again. And then maybe on that second time they get approved. So it's kind of a mixed bag, but, that's just kind of what we prepare the patients for ahead of time that we don't know exactly. But, eventually it's only been a few years since FDA approval occurred. So a few more years from now, it should be much easier and a faster process.
That's super. That's super. So for the therapists listening, if they have patients and they're worried about reimbursement, the good news is there is a pathway. There might have to be some, just like anything else we want to get for our patients, some justification, additional paperwork needed, but there is an opportunity to get some reimbursement, if not 100% reimbursement. So that's going to be on a case-by-case basis, which is fantastic. One thing we did not discuss when we were going through the research is who actually is a good candidate for Vivistim. I know later we'll transition into a couple case studies that you've done to get people to qualify. We'll save that towards the end of the podcast. But for now, who is the ideal person for Vivistim?
Yeah, very good question. Because unfortunately, at this moment, not for absolutely every patient who has upper extremity deficits. But to kind of explain why certain movements are needed, we kind of have to go back to that. Vivistim only works if we're pairing with active movement to begin with, hundreds of repetitions, primarily task-specific training. So, you kind of have to look at your patient and let's say they have upper limb deficits. If someone let's say they had very high tone and they could not move out of that barely at all, and they had no distal function specifically, they may not be the best candidate because how would we get in 300 active repetitions? So if you kind of imagine that in your head of the reason why this is, that kind of explains it. Because what would we stimulate with? So in general, the primary thing that I look for is having at least one digit, having active extension. Usually if it's only one digit, it might be the thumb first. So that's what I look for at the bare minimum. A patient who has more distal function, like maybe they can open their fingers, but they can't isolate them so that they don't have that like higher level of coordination. That would be an even better candidate, meaning that they would be, you'd be able to get in so many meaningful repetitions and the sessions would be very salient. and they would probably meet their goals much quicker than a lower level patient that to start with. That patient might not meet all of their goals in 6 weeks. They might need more in-clinic therapy, or they might just need to work more at home until they reach their goals, since they're starting at a lower point. So that's the main thing. We need to find people who can at least move their arm a little bit away from their body so we can get in hundreds of repetitions. And the big thing is at least one finger having digit extension.
So yeah, because you can imagine even if you just had the thumb, I mean, the things you can do to incorporate the affected side into purposeful tasks is great. You're just looking for that flicker of hope. It's a game of inches at the end of the day, right? Just give me those. It's all those micro goals too that we've talked about before. Is if I can just get a twitch or a flicker of movement, patient sees that, that's their motivation to continue to improve. Then that's pretty sweet. So you have those folks who are clearly good candidates. They hear about Vivistim through their therapist. How do they actually access the treatment? So if a therapist is listening right now and they're in the middle of nowhere and they just learned, oh my gosh, this is amazing, I want to try this with my patients, what should they be doing to get their patients hooked up?
Yeah. So Vivistim is, if you're listening from the US, Vivistim is, I would say, almost all across the country, it seems. They're expanding and trying to make this more accessible to people everywhere. But I guess probably going on the website, like vivistim.com, would help to kind of connect you with a local representative for the company, because that's where you would need to start with if you're listening in and you haven't heard about it at all before. Because there does need to be sort of a pathway in place. But one patient who's interested, or you on this call being interested, could kind of ignite the excitement to get a pathway going in your system. Because let's say if you are in your town, even if a patient may be willing to travel, but there does need to be some surgeon who will be trained and ready within a accessible area for them to get to. And then your clinic or a clinic wherever they end up going to, there needs to be somewhere where the patient can go where, all the I's are dotted and the T's are crossed, or however you say that, where all the little bit of paperwork is done, where, you can offer Vivistim and have that laptop I mentioned and offer the services. So, but the fun thing is though, that, just from listening here, if you had a patient in mind, you could potentially be the one that brings this up to your clinic or your health system and get this rolling.
So if I'm a therapist interested in bringing Vivistim to my clinic, is there training that needs to be involved? Is there an investment? Does the clinic have to purchase anything? What's that road look like if you want to start doing Vivistim in your own little practice or your clinic or hospital?
So for an actual clinic, there is no investment. The laptop I mentioned, like I said, very simple. It's actually on a loaner agreement. Usually like the clinic I work at, we have several therapists. We have we've had almost 25 different Vivistim patients just at that specific clinic. So we have several of the laptops just in case one's not charged or something happens. And then what was the other part of that question, Henry? Sorry, you said investment.
What's the onboarding look like? Is there training needed?
Yeah. So then the usually like a local team member that works for the company microtransponder who makes Vivistim, their role might be to educate the therapist and the therapy, like the clinic leaders. So just telling them what is Vivistim, just like how you're listening to this podcast of like learning about what it is. The actual training on how to treat the patients, it can be, the minimal training can be very simple. Like I mentioned how to click. It's not very complicated, but as far as task-specific training and the type of therapy that should be paired with Vivistim, I guess it depends what clinic you work at and what type of therapy you do. You may need more training if you are not typically doing like a lot of active repetitions. If you're more, if you are like kind of reflecting right now and saying, I do a lot of passive treatment. And so that's a big shift in your treatment style. There might be more training on that end. And that's kind of where what I do as a consultant is I teach CE courses and kind of train therapists on task-specific training. But the actual like usage of the laptop and how to stimulate is very simple, honestly. Maybe in general, you might need 2 or 3 hours of like meetings and trainings with the team. And then the great thing is that the representatives for the company that make Vivistim really care about their outcomes. They care about finding the right candidate and making sure the therapist feels comfortable with the technology.
The success of Vivistim is only as good as the therapist that's going to be doing it, right? It's the tool, right? But it's the person who's guiding the tool, the hands behind the tool. And if you could have, same patient, 2 different therapists, one adopting all the latest advances in neurorehabilitation, the other one clueless when it comes to neuro treatment, you're going to see different results. Again, because stimming the vagus nerve is the boost, but it has to be complementary to the actual evidence-based practice, which you did pass specific training, which means you have to qualify, which I want to lead to my next topic, which is some exciting information that you were able to do and collect data. There's a lot of people who don't qualify, right? And so when I think about my journey at Sabo, the reason why that SaboFlex was created was most people, remember, if you look at the CIMT research, 20% of people qualify for CIMT. And that was 15, 20 years ago when they did that study, but 80% did not have adequate movement to qualify for CIMT. So what are we doing for the 80%? And that's when Sabo was created, and that's when we created the SaboFlex to address those patients and try to get them involved in task training. Well, you being a neuro nerd, a fellow neuro nerd, of course, you have multiple tools in your clinic. One of which is some of the Sabo devices. And so when we were talking many months ago, we were discussing what do we do with those severely impaired patients? Because we know that possibly part of this recipe for success is stimming the vagus nerve. So how do we get patients to get to the level where they can qualify for Vivistim treatment? So then we have to actually roll up the sleeves and say, okay, here's that 80% group. Here's our chronic moderate to severe hemiplegic patients. What can we do to get them to either get some digit extension, some thumb extension, a little bit more movement in the shoulder and elbow, of course, but reduce some of that plasticity? So you decided to informally track multiple patients that did not qualify originally for Vivistim, work on a evidence-based protocol and strategy based on all the years of research, which included, of course, trying to get more strength in the shoulder and elbow, reduce spasticity, but engage the hand using different orthoses, including Sabo. So what I'd like to do with the remaining portion of our time is learn more about your patients you tested. What did you do? These are folks that didn't qualify originally for Vivistim. They didn't have finger extension. Did any of them end up qualifying? And what is your recommendation moving forward?
Yeah.
Does it sound good?
Yeah. Yep. That sounds great. Yeah. And this was really exciting because that's something like, this is what keeps me up at night, even before Vivistim, is how do we get these fingers open, right? And I think too, Henry, I don't know if I told you this point, but one of the reasons why I really wanted to do this too, and why I thought this would be effective, is that I did have I was provided like a trial of the Stim 1, which is the wireless NES.
Sabo Stim 1 wireless eStim device.
And this was before we tried this. And I did have a patient who had higher tone. And even though I tell all my patients to use NMES for digit and wrist extension, it seemed to me that the wireless one from Sabo led to better compliance. Like I felt like because I saw this man have no digit extension. And after maybe it was a couple months, I wish I would have tracked it better to kind of publish this or something. But he did have digit extension of all of his digits, and he was a chronic stroke patient. The only thing I can think of is that the patients I tell who use their typical wired unit, maybe it's, too much of a hassle. Maybe it's hard for them to use it in a functional way, like FES. But my point is that I think that's kind of what really got me excited and said, let me try this, because I feel like that being wireless in itself, I feel like it seems to improve the rate of compliance and how often they're going to use it. So
yeah, I agree.
So for these 3 cases, these 3 patients we were seeing, all of them are chronic ischemic stroke patients. So chronic. So that means they kind of range from, if I remember right, anywhere from 9 months to a couple years post-stroke. All had at least have some degree of hypertonicity in at least their distal portion of their upper extremity. So with the time, especially because 2 of them had absolutely no digit extension at the time. One had some digit extension, but had little to no shoulder movement. So even with a goniometer, if we were sitting upright, kind of against gravity, we had no range of motion in the shoulder. So that was kind of that patient hindrance of why, okay, we probably can't get enough repetitions with that little proximal movement. So what we did was all 3 patients received a trial of the stable mobile arm support, the mini, right, Henry, the one that attaches to a table or a desk.
Yeah. So the mini, the mobile arm support is just a de-weighting device for folks that have a lot of weakness in the shoulders. So it's more gravity eliminated movement so they can get the reps in. Yep.
And then they also got a stable glove. So if you guys aren't familiar, the one, well, if someone has active flexion but not extension, the rubber bands will help those fingers open up, basically, in a nutshell. So you get functional task practice in. And just like I mentioned, the Sabo Stim 1, the wireless eStim unit. So those 3 individuals received all of their items, and we had a plan to do pre and post testing for about a 12-week period, since this was real life in a clinic, not a controlled trial. Some of them, we did testing at like 13 weeks, 15 weeks, but really it's been pretty doable. The instruction for all these patients was to use, several times per week, ideally about 5 times per week, about an hour a day of any device they want to, or a combination, because of course you technically could use all 3 items at the same time. It might be a little hard for someone at home to do, but you could, right? And then in the clinic, we spent at least 1 full session kind of getting them comfortable with their mobile arm support, giving them ideas. One in particular, I recall, explaining the one who has limited proximal movement. We said, can we do like fold some laundries? And she does have some distal, so that like, how can we make this functional, right? How can we kind of prepare you, get this arm used in your real life task and be salient rather than just like lift up 30 times, right? So, and then basically, right before they received these items, we did look at their Fugl-Meyer scores and among others, like goniometer measurements, but primarily the Fugl-Meyer and the box and box test is what I looked at for these patients. Pull them up on my end so I remember. But let's see, 2 out of the 3 actually started with a score of 0 on the box and blocks test. So if you're familiar with that test, right, you need to be able to open your fingers, have enough control to pick up a 1-inch block and drop it all the way over. So you need to have some reaching too, right?
So 2 out of 3 couldn't even do it.
Mm-hmm.
Okay.
Yeah. So what we did, though, I will say as like a caveat, these are very low level patients who had 0 digit extension. So even from the beginning, even before this trial, every time we did attempt the box and blocks, and then as I'll mention when we go forward, if they could not do the real standardized method, we would modify it, whether we put the box and blocks test instead of being on a table, we might put it on the lap. Or, as I'll mention, when it's specific to the individual cases, we might help them place the block, but then they have to actively let go of the block on their own. So just to kind of note that we modified the test, but the Fugl-Meyer, of course, would be completed standardized. So we'll break this down. Let's say patient number 1, let's call her Sally. Okay. So she was one of the individuals with no active digit extension. Started with a score of a 17 on the Fugl-Meyer. So the Fugl-Meyer, the upper extremity motor portion, is out of 66 points. I would guess that most people who listen to the podcast might not use this in clinical, right? That's why I'm finding most people don't use the Fugl-Meyer. But just have that in your head. It's out of 66 points. You basically move in and then out of synergy patterns. And it kind of goes from proximal to distal. Basically, her box and block score after 12 weeks of using all 3 products, which she did, and devices, I should say, I guess, which she averaged about 3 hours, 5 days a week. So she kind of alternated, but she primarily used stable glove and the Stim 1 for her. Like that was just kind of her preference of what she felt like was the most impactful. And she did not just, practice like simple, like active opening and closing. She would use some thin items like a Jenga block or a playing card and practice grasp and release, or any type of like anything throughout her day during those 3-hour period that she needed to pick up anyway, that she could practice with. So that was kind of what she made her own protocol for this about 12-week period. So when we first started, when she first got these devices, we did that modified version of the box and blocks test where we handed the blocks, but she had to reach over and actively let go. Because of tenodesis, she did get a score of 4, right? She was able to kind of let her wrist down and just passively let go of the block. So, that's all right. That's where we were at. So that's something I know we would document. After about 12 weeks, she got up to a score of a 22 on the box and blocks test. Still doing it the same way where we helped her place them, but she did develop active digit extension.
So the difference, instead of using tenodesis to drop the wrist to passively open up the fingers, you could maintain her wrist in an appropriate position to actively fire the extensors to release the block. That's amazing. And that was up for how many weeks?
I guess it was about 15 weeks by the time that we did testing for her.
So that individual then became appropriate to qualify for Vivistim at that point because they showed active digit extension. That's fantastic. That was Sally, right? Sally the rock star?
Yes, Sally. And then 2 on the Fugel-Meyer, her score went from a 17 out of 66 to a 27 out of 66. And most notably, I had kind of put a note here. Again, if you don't know specifically about it, the score on shoulder abduction went from partial to full. Supination went from 0 to partial. And the most impactful for me is that finger extension, mass extension on that test went from none, 0, to partial.
And that makes, when you think about it, I was saying earlier in the podcast, you have the main act or the leading actors, which is the task training. And then you had the supporting cast, which are devices that are going to be used to augment the movement that they don't have, which in this case is the e-stim and the glove. So progress is going to be made if you have the right tools and the right treatment approach. Now, what we want to do is see if we can, double down that progress through the use of the Vivistim while still doing those specific tasks. It's not like you then stop doing everything that you were doing. You keep doing it. You're just doubling down. So that sounds fantastic. While we still have a few minutes left, how did you said there was 2 more people you worked with?
Yep. So let's see. One other individual, let's call this one Debbie. She was one that had some distal function, had some digit extension, but proximal was the one that was very limited. Really no tests, no active shoulder flexion or abduction against gravity. She used she used all 3 devices, but varied them 1 hour a day, nearly every day of the week. So in a 12-week period, her box and block score, which we did her test on the lap because of the limited proximal control. She went from a 0 to a 4 on the test. And her Fugel-Meyer this one was pretty wild, went from a 16 to a 29. What? The hand section specifically went from 5 to 11. So that could look like maybe she didn't have the spherical grasp before because her fingers didn't open enough, and then they did. So she could gain a lot of points in that section.
So with her, although she had a 0 on the box and block, so again, she did not have any digit extension to start. And she also didn't have a lot of shoulder movement, it sounds like, right? No digit extension, no shoulder?
She did have partial digit extension to start. She was the one, but very proximally impaired.
If you're proximally impaired, you're not going to be able to do the 300 reps.
Yeah.
So how did she end up doing after her, how many weeks was it? 15 weeks with her too? Or?
Yeah, so blocks went from 0 to 4. Fugel-Meyer went from 16 to 29.
So did she, at the end of the 12 weeks with Debbie, knowing that she had pretty involved shoulder limitation, did you get to a point where you thought you were comfortable with having her qualify for Vivistim to get the reps that she would need, or was she still needing some work after the 12 weeks?
No, absolutely right. And in present day, we're actually just waiting for her to get her approval from her insurance.
That's fantastic.
Yeah. She's ready. She's excited.
Those are potentially 2 patients that you would have said, sorry, you don't qualify. Then you go back to your traditional approach and you just move on. And then there you go.
If I knew we're insurance by now, we would have.
It's fantastic.
Right.
And then what was the third client?
And the third one, let's call him Matt.
We got a guy. Good, Matt. By the way, the theme so far with Debbie and Sally was they were very compliant. So I haven't heard yet you say, this person did it 1 time a week because they were too busy and they made fantastic results. I'm hearing 3 hours per day, 5 days per week with Sally, and I'm hearing 1 hour per day, every day with Debbie. How was Matt?
Matt was not as compliant.
Oh, sorry, the guys. What's up with that?
Yeah, you're right about that. No. He still used them, but he did, he can give me a clear amount of like how often, how many times, right? He did use the stim one the most often. So that was, maybe this will give us some information because he did do very well distally. So he did use that the most often. He specifically did do it for digit extension primarily. So his box and block score, which we did do that modified version, went from where we placed, and then he's got a reach over actively release, went from a 0 to a 5 after 12 weeks. His Fugl-Meyer, we missed his Fugl-Meyer score to begin with, so I can't look at that, but he went from 0, no active digit extension, he was actually developing more and more tone. So I think that's too why he might not have used the glove as much. So for him, maybe a Sableplex would have been more appropriate as his tone was kind of a little bit on that borderline level, harder to get the glove on for him. It sounded like, but he did develop active digit extension, and he's also just waiting for approval now from his insurance to pursue Vivistim, where he was not a candidate before this 12-week period. So really exciting. They're all candidates now.
That's amazing.
I expect that to happen for all of them, especially Matt, who I was like, wait, you're not, like how often are you using these things? I wasn't sure. But the stim, at least he prioritized the NMES.
Yeah, that's absolutely amazing to see that that you were able to progress them. It says a lot about you and your practice, and obviously how you're addressing the treatment interventions, but also, kudos to the patients for staying motivated and compliant, so they can see the progress. And sometimes it's just a matter of educating the patient on, hey, here's what stage you're at in your recovery. I like to use the Brent's from stages, but here's what stage you're at in your recovery. Here's where we want to go. Patients don't even know what they're currently at. They don't know what the next stage is. If we can tell them what the next stage is, they have something to shoot for. So when we say, okay, this is where we want to be, and we're thinking hopefully in the next 2-3 months, we can make those small gains, then they have a goal. And obviously now their next goal is going to be set up hopefully with the Vivistim treatment. And then obviously continue to make more progress. So thanks for sharing those 3 examples. I think that's helpful for the audience to hear. You've been doing this a while. Where do we go from here as far as future recommendations? What's missing? If you had that perfect world moment where all the stars align, we talked about taking the latest evidence and combining it with something like stimming the vagus nerve. 5 years from now, 10 years from now, do you see anything changing, or what would you think is the next big thing that needs to take place to really take this momentum and keep going?
Oh, that's a good question. I don't know. I hope 5 years from now that we can longer sessions that are reimbursed in therapy is number one. I hope that is more of a norm. I hope that VNS peer therapy becomes a bit more of a standard of care. I think there's still, right? Like, it's different for therapists to be educating patients on something like this that does involve an outpatient procedure. I think we're still kind of getting used to that comfort zone. And, I guess we'll see. There's a lot more, there's trials on deep brain stimulation, and, who knows what else will come to be 5, 10, 15 years from now. But I know for right now, I think there are some actual like real things that work that maybe we're just not using yet. I mean, we're not using it enough. I don't think that before kind of me experiencing this like 12-week little trial we did, I don't think any of my patients were, if they did buy a Sabo glove and they did use eStim, I don't think that they were doing it as much as I asked them to do in this 12-week period. So maybe we really just need to figure out what do we know right now and do it the right way. And when it comes to Vivistim, the great thing is that we know task-specific training works with it. But even for these patients that we talked about, even when they do start Vivistim, I would still, if I need to, I would still be able and want to use the Sabo glove or NMES in functional way to kind of super boost their recovery. That's what I do right now. And I would recommend that if needed to get more repetitions in. Mm-hmm.
Yep, I agree. I think being a neurotherapist, not a lot of people want to sign up to be a neurotherapist. There's a lot of tears and sweat in this business, right? And a lot of the patients don't make the progress that we hope they could make. if you're an orthotherapist, just follow the playbook, follow the protocol. Chances are they're going to get back to their activities of daily living or their occupation without too much of an issue. Of course, there's always exceptions and there's chronic pain and chronic conditions, but I'm overgeneralizing. But compared to neuro, when you started to be a neuro soldier, it is going to be tough. And, not a lot of, that's why these small victories we have to celebrate. And I think today this discussion is a small victory for millions of patients and therapists. They have options. So, I think the headlines are, we've come a long way, but we have a long way to go. And I think being in this business, being a clinician, for a couple decades now, I've seen a lot. And, when I throw every evidence-based approach at my patients and they still don't make the progress and they're compliant, that's frustrating. And then I see another patient who's not as compliant and they do better. And it's a head scratcher. So I think over time, I'd like to see the science align more with reimbursement. And, because I think everyone feels that we're on the right path. We just need to do more. It has to be more intense. And if we can boost it with things like Vivistim, definitely do it. So thank you so much for kind of giving us a great overview of what Vivistim is. Thanks for, working with those patients who didn't qualify and sharing that story. I think that's fantastic. Yeah. And how do people reach you? Let's say therapists want to follow up and they want to, dive a little bit deeper and learn more about, today's talk. Is there an easy way to reach you?
Yes, you can definitely always send a message on the Instagram page. It's at neuro_OTS. Or I'm happy to have emails. Basically my first and last name, Amanda Saylor, 34@gmail.com. I'd be happy to answer questions, or as we mentioned before about, just connecting with maybe a Vivistim rep. I can definitely be of help with that and navigating that to get this rolling by you if you're interested.
Wonderful. Well, thank you so much, Amanda. I hope the audience enjoyed our talk today. And I appreciate all you're doing to help move the profession forward.
Thank you, Henry.
All right. Well, you have a good one.
Thank you for tuning in to the No Plateau Podcast. Please make sure to like and subscribe to stay up to date on more stroke and brain injury recovery stories. The No Plateau Podcast is intended to give you an insight into stroke and brain injury survivors' journeys. Any opinions given on this podcast are strictly the individual's, and we do not suggest that you necessarily hold the same viewpoints as anyone on this podcast. This podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with any questions you may have regarding a medical condition. Reliance on any information provided by the No Plateau Podcast is solely at your own risk.